of us. Today is the auspicious occasion of Ganesh Chaturthi. So I would like to wish happy Ganesh Chaturthi. And today we have eminent endocrinologist with us, Dr. DC Sharma sir. He is one of the first endocrinologists in Rajasthan. Today, along with Dr. SK Sharma sir, have started DM endocrinology seat in the SMS Medical College. He is has many international and national articles to his credit, and he is very eminent speaker and teachers of very eminent along with very eminent speaker. So today I would like to good evening sir. So today sir, as you know, we have various DPP4 inhibitors and various SGLT2 inhibitors in our armamentarium for the management of type 2 diabetes. So the topic for today's discussion is the combination of SGLT2 and DPP4 inhibitor. So what are your thoughts with regard to Empagliflozin and Linagliptin early in the type 2 diabetes management in various patients with diabetes with various comorbidities?
Thank you, Dr. Vinod. At the outset, my sincere thanks for the kind introduction and the kind words. Regarding the timely initiation and early combination of the two drugs, let us start with the role of glycemic control achieved early in the course of diabetes mellitus. See, few years ago, say 2-3 decades back, the role of good glycemic control versus complications was debatable. And the landmark trials like UKPDS in type 2 and ECCT in type 1, those studies in type 2, clarified the role of good glycemic control in preventing long-term microvascular complications and to some extent macrovascular complications. Further, follow-up cohorts of the study, cohorts like UKPDS patients and other cohorts of some long-term trials clarified that even macrovascular complications is favorably affected. Long-term effects of glucose control also reduces the chances of macrovascular complications, especially cardiovascular complications. So now there is no doubt about the role of glycemic control in preventing micro as well as macrovascular complications. The question comes, how early? Further on, there are several studies which have clarified that early the glycemic control is achieved, better would be and more would be the protection in terms of both micro as well as macrovascular complications. Recently, there have been some studies which have compared two cohorts. In one cohort, right from beginning, the glycemic control was, good glycemic control was offered. In the other arm, there were patients who were offered glycemic control after having an initial uncontrolled period. So the result was patients who were offered good glycemic control, they had significantly less chances of complication, both micro as well as macrovascular complication. So it's clear now that good glycemic control needs to be achieved and needs to be maintained throughout the course of disease.
Yes, sir. Definitely, sir. So, sir, we have with various trials and with emerging data, we have came up that cardio, renal, and metabolic continuum that has been impacted, or we can say that can be targeted with particular newer agents. So, sir, how do you bring together vast emerging evidence for this cardio, renal, and metabolic risk modification and various pleiotropic benefits, and along with risk of general tract infection? So, with use of this single pill agents of Empagliflozin and Linagliptin in Indian settings.
So the question is a combination of SGLT2 inhibitor and DPP4 inhibitors in a diabetic patient, the benefits and long-term protection. See, if you review the ADA 2022 ADA criteria, the rationale of combining two drugs comes very early. As per the guidelines, you are recommended to initiate with lifestyle measures in every diabetic patient and with metformin in majority of the patient. But let us review what are the indications of initiating with dual therapy right from beginning. So there have been, again, I would like to quote some studies like there was a verified trial. This verified trial was basically in recently diagnosed type 2 patients whose HbA1c was above 1.5% at initiation of or at the onset of diabetes. And what was was found was in the cohort, in the group in which the two drugs were combined right from beginning versus only metformin, the result at the end of the study was that patients who were put on combination therapy right from beginning had a better and more importantly durable glycemic control. So what we would like in a diabetic patient to achieve is not only glycemic control but durable glycemic control. And the recommendation for initiating dual drug therapy or two drugs right from beginning is patients who have HbA1c above 1.5% at the time of diagnosis, at the time when a person requires pharmacotherapy. These patients are unlikely to achieve glycemic control with just one type of drug. So in these patients, two drugs right from beginning would be helpful in achieving effective and durable glycemic control. Now,
Yes.
while we treat a diabetic patient, it's a well-known fact that diabetes is now considered to be a vascular disease. We are
Yes.
concerned more about the vascular component of treating diabetic patient because the risk of a diabetic patient developing atherosclerotic cardiovascular disease is almost 2.5 to 3 times higher as compared to the background population. So, achieving good glycemic control and also using some of the drugs which effectively modify the cardiac risk is the dictum and is the need of the hour. Because early glycemic control and using the drugs would prevent the progression of atherosclerosis process as compared to the conventional approach. And the legacy effect of the glucose control and other aspects of preventing complications would also be achieved if you achieve glycemic control right from beginning. So there is a definite role of two drugs right from beginning. Now regarding which drugs to use, today the recommendation of treating a diabetic patient is patient-centered approach. Patient-centered approach means based on the patient's needs. You have to offer drug treatment. Say for example, we take into account various factors: age of the patient, associated comorbidities, presence of complications, patient's social background, his family support, his need to lose weight or maintain weight. If the patient is obese, obviously the therapy should be such which should be helpful to reduce the weight. If the patient is elderly, having cardiac disease already, we would at all costs like to avoid hypoglycemia. So need to avoid hypoglycemia and need to modify the cardiac risk factors and not to forget the cost of the drug and several other factors. So we call it patient-centered approach. So while we decide targets for a given patient, we decide type of therapy for the given patient, we take into account all these factors into consideration. And since majority of the patients have cardiac risk being diabetic, and also in majority of the patient there are other comorbidities present in the patient. Say for example, 40% of diabetic patients also have hypertension. More than this number, patient also have diabetic dyslipidemia. If there is a family history of atherosclerotic cardiovascular disease, if there is a family history of nephropathy, then these patients are at a very high risk of having atherosclerotic cardiovascular disease and also heart failure. So you have to keep in mind this risk and you offer drugs accordingly. Let us evaluate and let us discuss what is the benefit of EMPA and LINA combination, or I would say SGLT2 inhibitor and anti-DPP4 inhibitor class of the drug. Or what is the benefit? See,
Yes,
these
sir.
drugs are recommended after metformin.
Yes,
And
sir.
if you review the guidelines 2022,
Yes, sir.
I was mentioning the patient-centered approach. So the recommendation is if the patient has established cardiovascular disease, if the patient has established heart failure, if the patient has evidence of nephropathy, or if the patient has multiple risk factors which puts him at a higher risk of having atherosclerotic cardiovascular disease or heart failure, then you are recommended to use either SGLT2 inhibitors or GLP-1 receptor agonist with metformin. If the patient is already on metformin, you are recommended to choose either of the two drugs. If there is a predominant nephropathy, heart failure, or a component of these or multiple risk factors, then you're more likely to use the GLP-1 inhibitors. If it's a purely atherosclerotic cardiovascular disease, then you are more recommended to use GLP-1 receptor agonist along with metformin. So again, the patient-related factors.
Yes.
And as I mentioned, if there is a need to avoid hypoglycemia, along with metformin, you use drugs which have minimal risk of causing hypoglycemia, say DPP-1 inhibitors, SGLT2 inhibitors, or if clinically indicated, drugs like small dose of glutathione. If the compelling need is to reduce weight, or patient should not put on weight, then you would like to avoid drugs which have propensity to cause weight gain, say sulfonylurea, glitazones, or if you can avoid insulin. So, and of course, the cost of the drug, as I mentioned, we would like to choose and take help of the drugs which are relatively economic to the patient.
Yes, sir.
Okay.
Definitely, sir. You have very well explained the from the beginning of the legacy effect to the rationale of early initiation of these particular agents, particularly the combination of this empagliflozin and linagliptin. Along with, you also clarified the rationale for combining these two agents. So, sir, what are the clinical experiences you have noticed or you have experienced with regard to this fixed drug combination of empagliflozin and this linagliptin, and rate of observed various side effects, or per se we can say episodes of hypoglycemia, and is it any decline in genital tract infection with regard to use of combination as as compared to use of only SGLT2 inhibitor without TPP-4 inhibitor? So, what's your take on these particular points, sir? Regarding, sir, side effects and regarding genital tract infection, and with regard to hypoglycemia, you have very much explained the point. So what's point or what's your take on the risk of genital tract infection with combination of therapy, sir?
So thank you, Dr. Vinod, for asking a very interesting question. And since the question is long, I'll start elaborating upon all the benefits and maybe the risk one by one. So while we treat a diabetic patient, the
Yes,
first
sir.
and foremost goal is to achieve effective glycemic control. SGLT2 inhibitors are known to be reducing HbA1c to the tune of 0.8 to almost 1%. DPP-4 inhibitors are moderately effective in lowering HbA1c, say to the tune of 0.5 to 0.6 or 0.7%. The two drugs combined are very effective. They decrease HbA1c to a tune of 1.81% some of the studies, when the baseline HbA1c was 8.5%. In terms of reduction of fasting PP blood glucose, they reduce fasting plasma glucose to the extent of 32 milligram per deciliter, and PP blood glucose to the tune of 50 to 70 milligram per deciliter, when the fasting PP blood glucose was in the range of 150 and PP blood glucose in the range of 220 likewise. So, meaning thereby that this combination is effective in lowering glucose control. The studies have also shown that these drugs provide durable glycemic control, especially there are now good studies available with DPP-4 inhibitors. So durable and effective glycemic control is achieved with a combination, number one. Number two, we have been discussing about the reduction of the cardiac risk. So again, I would like to refer to these studies like Empagliflozin study, which was the landmark study with empagliflozin. And for the first time, any diabetic drug showed such an effective and early risk reduction in terms of reduction of the MACE, in terms of lowering heart failure risk, all-cause mortality, and life. Linagliptin, drug from the class DPP-4 inhibitors, is also good in terms of no added risk to cardiovascular system and no added risk to heart failure risk. Rather, there are indirect evidences. There are some but milder evidences that they are cardiac friendly renal. Linagliptin especially is helpful in reducing the renal risk. The Carmelina and Carmelina studies have very clearly shown that there is a reduction in the macroalbuminuria, progression of macro to macroalbuminuria, rather reversal from macroalbuminuria to macroalbuminuria. So renal protective effect, and a diabetic patient when develops nephropathy puts him at a very high risk of having heart disease. So we have to treat the cardiometabolic renal continuum. You very rightly pointed out at the beginning, the cardio-renal metabolic continuum, and most of the patients have falls in one or other spectrum of the cardio-renal metabolic risk. Say, patient having multiple risk factors at the beginning, or patient with initiation of some complication, or end-stage problems. Across the spectrum, these drugs help modify or reduce the risk. I discussed about the cardiac risk, heart failure risk, renal risk, and there are several mechanisms to explain this risk. In addition to there is, I also discussed the durable glycemic control, and this durable glycemic control is postulated to be because of the preservation of the beta cells. The beta cells have been found to be functioning better with DPP4 inhibitors and also when combined with SGLT2 inhibitors. There are some studies, there are experimental studies, at least in animal experiments that the beta cells have been found to be better differentiated. There is a proliferation of the beta cells, and beta cell mass and function is found to be improved with DPP4 inhibitors and also when SGLT2 inhibitors are added. So this may be these experiments support that the durable glycemic control is possibly because of the better beta cell preservation and as per the experimental evidence, beta cell regeneration.
Yes, sir. Thank you very much, sir. So you have clearly shown the various cardio-renal benefits of particularly SGLT2 inhibitor, and with linagliptin, some trials or some animal studies have shown the beta cell preservation as well as renoprotective effects as well. So you also mentioned the various mechanisms behind the renal protective effects of SGLT2 inhibitor. So, sir, what are the clinical implications of these renal outcome studies like EMPA kidney and of this particular Empagliflozin trials? So that will be implicated in the real world scenarios. So is these randomized clinical trials results can be like translated to the real world scenarios also? Or like
Right.
we need to have some real world data to like to have or to wait for some real world data too. Yes, sir.
See, based on the landmark trials, the recommendations were changed. Rather, I would say they were guideline changing trials.
Yes,
And
sir.
based on these, recent ADA ESD guidelines were incorporated in their place, and in the hierarchy they were mentioned earlier.
Yes, sir. So it's very clearly explained by you that this particularly SGLT2 inhibitor, the empagliflozin, that have we have seen from various trials like EMPAREG and with newer trials of EMPA kidney also. So with this, along with
even you were mentioning the real world studies also. There are real world data also.
Yes, sir.
Which reinforce the RCTs in terms of reduction of the risk and
Yes, sir. So we are at present we are confident enough to use the SGLT2 inhibitors along with the various DPP4 inhibitors. So combining these two agents will be like for along with the effective glycemic achievement would help in achieving renal protective, cardioprotective effects, and these effects or these protective effects can be translated to better glycemic as well as better cardiorenal benefits to our patients. So I think its message is very loud and clear that the early initiation, or we can say hitting hard at the initiation of the pathology, the management of type 2 diabetes, as we all know, it's not a glucocentric approach now, it's a holistic approach targeting the cardiorenal and metabolic aspect. So early use of these agents like empagliflozin and linagliptin would result in along with better achievement of glycemia and also having better protective effect on the metabolic aspect as well as cardiovascular and as well as renal aspect also. So with this, I would like to thank Mr. Sharma sir for enlightening on this particular topic and suggesting the very clear and loud message.
I forgot to reply some of the questions you asked, like
Yes,
the side effect profile and the benefits of combining the two drugs in terms of some side effects.
yes, sir. Yes, sir.
Like SGLT2 inhibitors as a class, they are known to cause some. You take some precaution because chances of genital mycotic infection is slightly increased.
Yes, sir.
And while you combine SGLT2 inhibitors with DP4 inhibitors, the studies have shown, the real world data have shown that the chances of genital mycotic infection is reduced when you
Yes, sir.
combine Empa with Lina. There is a rational, there is a theoretical explanation for this, and you achieve all the benefits like HbA1c reduction, no hypo, weight reduction, cardiac protection, and like that. One point we would like to suggest to the patients, and I would like to
Yes, sir. This point is well taken, sir.
reiterate
So,
with our colleagues is that what precautions should be given, what precautions should be observed, and what advice should be given to the patient while we prescribe SGLT2 inhibitors. See, the patient should be asked to maintain hydration at all the times, and no water, and take care of the hygiene. Clearly told how to manage it, and they should also be that when to report to a doctor. They should report to the doctor when they observe some they develop urinary infection, recurrent urinary, and also during acute sick day guidelines. Whenever the patient or they because of some medical or surgical illness, immediately report to the doctor that they are on. So early warning signs should be nausea, not feeling well, and likewise. Similarly, the doctor these drugs are to be avoided in acute emergency. Whenever a patient is on empagliflozin or PSC and they fall sick, to stop these drugs for a while, especially when the patient having recurrent diarrhea, surgical medical illness, whenever there is complicated UTIs, stop the drug and maybe reinitiate once this problem is.
yes,
So over to you.
sir. Yes, sir. Very important point safety of and also some people care of while prescribing. So, sir, one particular patient developed pyelonephritis, severe pyelonephritis. So, should we stop altogether the two inhibitors, reinitiate when pyelonephritis? In other words, the development of or history of pyelonephritis contraindicated. It's a kind of relative. So, please, so many of us
So,
may have.
so I mentioned that whenever a patient has complicated UTI, then I would add upper urinary tract infection, acute pyelonephritis, renal abscesses.
Yes,
So
sir.
we should avoid stop these drugs. If there is a history, which is now taken care by treating doctors and they give green signal. Now there is no more infection.
Yes,
You can
sir.
reinitiate, but with caution and with proper
Thank
keep
you.
patient under close surveillance
Hmm.
and see there is no problem.
Thank you very much, sir, for this talk. The clear-cut evidences with regard to vehicle trials, experimental animal trials, data to changer with regard to with various microvascular. Thank you very much, sir.
Thank you, Dr. V, for your nice introduction, and thanks, team Lupin, for supporting this program.